And then we just give the members, the audience, a few minutes to join.
Good.
So welcome, everyone. Nice to see you again for this month's edition of Neurology Report. I'm Dr. Tracy Milligan. I'm a neurologist at Newark Medical College and Westchester Medical Center. And I'll let Dr. Samuels introduce himself.
Martin Samuels from Boston with my Harrods coffee cup.
Professor of Neurology at Harvard Medical School and founding chair of the Department of Neurology at Brigham and Women's Hospital. I am going to start with a poll, and this is just a poll so we can see who is here today. There's just two questions. One is where you are right now, what continent you're on, and the second is what stage in training are you right now. And as soon as majority of people have answered, I'll share with you those results so we can see where everybody is coming from and a little bit about who everyone is. We'd like this to be interactive, so please use the Q&A or chat functions to interact with us. We will pose questions to the audience, and then we also like you to do some teaching of one another. So if you would like to expand on any of the teaching points that we're making or answer questions from the audience, please do so. That's what we want. We want to make this as interactive as possible, even using this webinar format.
Dr. Milligan, you left Antarctica off your list of continents.
I did, didn't I? Should we go and do a special edition from Antarctica some month, Marty?
Really, I think that would be good. This time of year, it's probably warmer than it is in Boston, so you know.
All right, and it looks like everybody, most people have answered, so I'm going to share the results with everyone so you can see. So we have people from all over the world, nobody from Australia today, but we are recording for our fellow, for people in Australia who might not be awake at this time, and people of all stages of training. So welcome, everyone. All right, and Marty, you have a case for us today.
Yes, I will present a patient to you, and we'll see how everybody participates in this. This is a 57-year-old man who was found unconscious, and he was admitted to the medical service. I've given you a date just so that you can tell the course, the pace of the illness. Admitted on June 29th, let's say. He has a history of coronary disease, alcohol use disorder, diabetes, and a seizure disorder, which has been thought to be due to alcohol withdrawal in the past. He's had several episodes of pancreatitis in the past and has hepatitis C. He was recently admitted to another hospital, OSH means outside hospital, for a lower extremity cellulitis and for alcohol withdrawal. And after a 10-day course of Bactrim, he was discharged to a homeless shelter on the 26th. His primary care doctor started morphine for leg pain on the 27th, after which his mental status improved after he received the Narcan. His toxic screen was positive for benzodiazepines and opioids. He was started on thiamine and folate. So there we are. His CK was 2000. He was treated with IV fluids. And on June 30th, he felt, quote, shaky, end quote, and was febrile at a temperature of 100.8. He was given lorazepam, which improved him somewhat. The next day, he was found drowsier and rigid. And he was given flumazenil, which is a benzo antagonist, 0.3 milligrams intravenously times 2, which did not help him. He was also on citalopram, 20 milligrams daily, but that was discontinued on his admission. Neurology was consulted. Dr. Milligan, do you want to ask people if they have any initial ideas about this before we go on to the admission?
Yes, let's hear from our audience, because this is, so the case presentation is that he was found down. And then you gave us with some of his prior information. And then if you just go back a slide, Marty, you don't mind. So he was admitted on the 29th after being found down. And then we have a little bit of information about what had happened just shortly before his admission, when he had been at another hospital and then saw his PCP. And then one slide forward. And so he's admitted on the 29th, and on the 30th, then he's on the medicine service, shaky, temperature 100.8. And then we see a little bit more that's developed. So let's hear, audience, what your thoughts are at this.
Well, I can actually put up this other slide where people think about it, because it's still part of the history.
Okay, all right.
It's just a complete list of his medications on that admission.
All right.
Remember, camprosate is a drug that's used to reduce the craving for alcohol. It's commonly used in people with alcohol use disorder. And the other drugs, I think everybody knows what they are. History of anaphylaxis from penicillin when he was a child. And he had a very hard life. His wife had committed suicide. He had found the body. He served in Vietnam, honorable discharge, but suffered from post-traumatic stress disorder, was homeless, living in a homeless shelter. So he had a very hard life. So I wonder what people are thinking now. What do you think, Dr. Milligan?
We'll hear a little bit what people are thinking so far. I think we're already hearing things people want to know, but you know, for example, there was a question about his renal function and urine analysis, but we'll get to more data. But another comment about opioids, SSRI, serotonin syndrome, unwitnessed seizures post-ictal encephalitis, acute kidney injury, morphine causing prolonged altered mental status, Wernicke's, wonderful thoughts. People wanting to know a little bit more, maybe from where their blood cultures from the outside hospital.
I don't know the answer to that, actually. Don't know whether he had blood cultures. Probably did, but I don't know that for sure.
Yeah, I think you did give us a couple of intriguing data points about the low-grade temperature, low-grade fever, 100.8. And then you had the word rigidity in there as well.
Yeah. Exactly.
So I think people are thinking about, you know, I was wondering about neuroleptic malignant syndrome, didn't see anything on the med list or by history, but then somebody else is putting in serotonin syndrome. So. Yeah.
Right, all good ideas. Here was his exam. At the time of the exam, the low-grade fever was gone. He was afebrile, with a normal blood pressure and a little bit of a tachycardia, sinus tachycardia. He was stuporous, by which we mean arousable not to voice, but to a noxious stimulus. His optic discs were said to be indistinct, and they couldn't see venous pulsations. This is one of the sort of an aside here. You should practice your fundoscopic examination technique on whoever you can practice it on your spouse, on your partner, somebody who's willing to let you look, because you really, I mean, this is why we call it the practice of medicine. You have to practice to the point where you ought to be able to always see venous pulsations. practice that on somebody who's cooperative. And just to test yourself, put a little tiny bit of pressure on the globe, which will bring them out because you're raising the intraocular pressure just a slight amount. Remember to look at the veins, not the arteries, as they come out of the disc, and you ought to be able to see them. You want to get to the point where if you don't see them, you're worried that it's if you never see them, then there's no marker about which to be worried. So you have to practice. It's very much like a cardiac auscultation. I remember when I first learned that in medical school, they gave us all stethoscopes put in our ears, and they play a recording or something. And at first you just couldn't hear that third sound, just couldn't hear it. But with practice, you get to the point where you can hear it. And then you know when it's absent, something's wrong. Well, that's what goes with the fundus examination. You really ought to do it on virtually every patient. One, because it makes you better, and two, it's very reassuring to people to have doctors look in their eyes. I mean, a lot of our patients have headaches, dizzy spells. And so I think getting close to somebody and looking in their fundus is therapeutic as well as diagnostic. Anyhow, the optic discs were indistinct, no venous pulsation. So if this were you, you'd be worried.
Very worrisome. And I'm just going to add to your instruction of people to practice the fundoscopic exam, because we are coming on some holidays where people are going to see people that they care about them. You've got some good people to practice on coming into your world. So bring your ophthalmoscope to the family events.
Yeah, very good entertainment for Passover and Easter. His left arm was flexed at the elbow and rigid. His left hand was clenched. His right arm was also rigid, but less so. And they said there was waxy flexibility, meaning that the examiner here is trying to transmit to you sort of an extrapyramidal quality that otherwise the examiner should have said that it was velocity dependent stiffness, which would be what you'd see with spasticity. The muscle special reflexes, which have many different names, most people call them tendon jerks. They're not a very good name for them. They're really proprioceptive reflexes. Those are increased: biceps, triceps, brachioradialis. Knee jerk, ankle jerk, all increased, and bilateral Babinski signs, the most reliable test in all of neurology.
And was there any mention about any nuchal rigidity?
He didn't have what we would really call meningismus, which is authentic nuchal rigidity. He was stiff all over. Nuchal rigidity really is a situation in which, when you flex the neck, the hips flex. And you remember Koenig and Brzezinski. So if you bend the neck, the hips flex, and if you flex the hips, the neck flexes. That's Koenig's sign. He didn't have that. So it wasn't suggestive of meningitis or meningismus, just stiff all over. And there's a combination of pyramidal and extrapyramidal trouble here, right? Hyperreflexia, Babinski signs, and waxy flexibility. Anybody have any ideas? What would you like to know next?
So we already have some things some questions people wanted to know as far as test results. There's a comment, DHPL given found down, DHPL. Do you know what that stands for?
DHPL. No, that person's going to have to clarify that one.
Hypoperfusion, maybe diffuse. I'm not sure. We need that written out. But also saying signs of increased ICP, diffuse hyperreflexia, showing the cortical spinal tract involvement. Comment, when I hear waxy flexibility, I think catalepsy, not cataplexy.
Thinking about what? I'm sorry, Dr. Milligan.
Epilepsy.
Let's see.
Delayed post-hypoxic leukoencephalopathy.
So people are worried about increased intracranial pressure, and they really should be, right? Because he's got an abnormal fundoscopic examination. He's stuporous, he's stiff and rigid and hyperreflexic and has Babinski signs. So I think you have to worry that he's got increased intracranial pressure.
A question, does he have catatonia? That's a question.
Catatonia is a syndrome in which people take unusual postures and don't relax. Like they'll hold their arm up, and you can put the arm in that position, it sort of stays there. It implies a psychosis, an acute psychosis. He didn't do that. He was stiff passively, but you couldn't put his arm in a position and it would stay there.
So I think, with the waxy flexibility, which was one of the descriptors, sometimes that's used in describing the state of catatonia. So maybe that's.
Yeah, this is one of these problems with catchphrases. There's a lot of these in medicine, unfortunately, that can transmit the wrong idea. Masked facies is another one. People say a patient has masked facies. They're trying to say it looks Parkinsonian to them. It's better to say it looks Parkinsonian to me than it does say masked facies, because the masked facies could be a lot of things. Could be myasthenia for that matter, right? So try not to use catchphrases like that. And I didn't use that term waxy flexibility. That was used at the other hospital, but you don't want to assume that it's catatonia because somebody else used the catchphrase. Well, here are the numbers. I think
before you do those, Marty, I really like this question from the audience about the were the pupils large?
No, the pupils were normal. They were 4 or 5 millimeters that reacted to light direct and consensually.
Mm-hmm. And any clonus or myoclonus?
There was no myoclonus. There probably was clonus. It wasn't mentioned. Clonus just means hyperreflexia. So basically, when a reflex is judged to be 4 on a scale of 4, that means that for every tap you get more than 1 jerk. That's clonus. So whether he had clonus, whether they sought clonus specifically or not, doesn't matter. They told you that he was hyperreflexia and had outgoing toes. That's all you need to know.
Yeah, I was wondering the same thing. Did he have clonus or not? And in my own head, I said, well, he's got upgoing toes and brisk reflexes. So, those go together. Thank you for the teaching, by the way, audience. People put, there's recently a link now about meningitis and the jolt acceleration, which is the most sensitive part for this meningismus. So thanks for that link. And did they get a salicylate level at the outside hospital?
That's a very good question. They did not. And when you look at the numbers, I think you can wonder about that even more.
All right, let's go.
So you want to walk through these numbers. So his gases on the 30th of June showed a PCO2 of 68, very elevated. A PO2 of 68, very depressed. A PCO2 of 30, hyperventilating. And a pH of 7.6, alkalotic. So he has a respiratory alkalosis on the 30th. On the next day, his PO2 is 81. His PCO2 is now 59, so he's retaining. And he has become acidotic. So he's not breathing normally, not breathing enough. So something has happened in the interim between the 30th and the 1st. And later on that day, the same day, his PCO2 has climbed all the way to 92. So this is obviously a very serious matter of narcosis, carbon dioxide narcosis. He's very acidotic and he's not breathing. His CKs were falling from 2454 on the 30th to 733 on the 1st. And then now look at his electrolytes. Sodium was 142, his potassium was 3. Glucose was high at 360. Remember, he was a diabetic. He was known to be a diabetic. His BUN is very low. Do you all remember how to calculate osmolality? Osmolality is really made up of 3 components. One is the serum sodium, which is the major component. So you multiply the serum sodium times 2. So it's 2 times 142 is 284 for openers. And then 1/18 of the blood sugar. Blood sugar is 360. And you get 1/3 of your BUN. So his BUN contributes very little. In any case, the calculated osmolality was 314. I just went through that with you. 2 times 142 plus 1/18 of the glucose and 1/3 of the BUN equals 314. And then they ordered it an osmolality in the lab, and they do that by freezing point depression. And they've calculated it was 384. So there's a gap of a huge gap, 70 osms between what they measured in the lab and what you calculated. That's an osmolar gap of 70. The normal osmolar gap is less than 10. It's made up of what are called idiogenic osms, of which we have a few, but this guy has way too many external osms coming from somewhere. And you can see his liver function tests, AST and ALT. Not that impressive. Alkaline phosphatase is a little elevated. Bilirubin is actually good. His ammonia is not elevated, 6 micrograms per deciliter. So that would have been something to worry about, would be ammonia toxicity from liver failure, but he doesn't have liver failure or hyperammonemia. And they did a lumbar puncture, and the opening pressure was in fact elevated at 240. It was acellular, essentially. There was 1 lymphocyte. The protein is normal. The glucose is high, but remember his simultaneous blood sugar was 360. So it's about what it should be. Spinal fluid is not very worrisome, is it? CT scan says no abnormalities. EEG is Dr. Milligan. We did get an EEG on this patient. You'll be happy to know.
Of course, of course. Very good.
The question was, could he be in status or something? Disorganized with a low voltage background, superimposed runs of bilateral anterior delta, no seizures. Admitted to the MICU, to the medical intensive care unit. Intubated. Obviously, he had to be intubated. His PCO2 is 90. Any comments about what do you think was happening here?
I want to, yes, audience, please put in your thoughts. What do we have here? Anion gap, metabolic acidosis, or respiratory acidosis, And so please put in your thoughts. We have a comment. It's like they added the potassium to the osmolality calculation, which added an effective osmolality. Potassium moves intracellular, extracellular, and so is usually not included.
Right. Potassium is not included. No. Mm-hmm. Which we didn't. We just multiplied 2 times 142 plus 1/18 of 360, and we got 314.
So we have our anion gap acidosis. So that's why you like that question about salicylate level.
Yeah, you wonder why he had a respiratory alkalosis. I mean, compensating for an acidosis, perhaps. Huh? Why was he hyperventilating? Down to a PCO2 of 30 on admission, and then it appeared that went away, and it was replaced by a very severe failure to breathe. So everybody can now say what they think is happening, and then we'll go on.
And just a note that the chat is disabled, so just add your comments in the Q&A. We're just use it as a chat, so please keep adding your comments in the Q&A. Anion gap metabolic acidosis plus osmolar gap, propylene glycol, or antifreeze or other causes.
Antifreeze for exactly some external osms, in the form of ethylene glycol, something like this. This could happen in the hospital, of course, because we sometimes add osms, like mannitol, for example, but that wasn't done. So there's a big osmolar gap that you have to try to explain.
And then there was just another comment that usually you'll see kidney failure at oxalate crystals.
Yes, you do. That's right. So let me take a little aside here and remind people about this issue of osmolality. Can I do that, Dr. Milligan? Is that?
I think we would love that.
So the normal osmolality run is between 280 and 295 milliosmoles per liter. And I've just told you how to calculate it. I wrote it out again for you here. 2 times the serum sodium. The K is meaningless. An 18th of the glucose and a 1/3 of the BUN. And we've already discussed this. And then it's measured in the lab with freezing point reduction, depression. So hyperosmolality is very common in critically ill patients. It's typically associated with volume depletion. And the possible causes of that would be a central kind of diabetes insipidus, or a nephrogenic diabetes insipidus with loss of water, an osmotic diuresis from glucose or mannitol or urea nitrogen, which wouldn't be the case here, right? Because the BUN was only 7. Don't forget, fever causes insensible loss. He had a fever transiently, but it really wasn't much of a fever, and it went away. And then there's this issue about external osms, which we've already raised the question. The management of this is very, very common in the medical service of any big hospital. And we're often called as neurologists because the mental status is abnormal. And the treatment really is metabolic treatment. Try to address the primary metabolic abnormality. For example, if it's hyperglycemia, you would treat with a small dose of insulin. By small dose, I mean 5 or 10 units of regular insulin, tiny dose. Always round up the usual suspects. Medications, poor nutrition, things that the person has taken. This question about ethylene glycol is a very good question. What was the person drinking antifreeze? It was not the case. And actually the acidosis, that mild transient acidosis wouldn't have been severe enough to be explained by that anyhow. And then you determine the free water needs separately. So you calculate the free water deficit, you calculate the ongoing free water losses, you calculate the evaporative losses, somewhere between 500 and 1,000 milliliters per day, increasing by 125 milliliters per day for every degree of body temperature over 37. So he doesn't get anything additional because his body temperature went back down to 37. Now let's turn the coin over and talk about hyponatremia. Let me get this thing out of my way so I see my own slides. So let me just remind you all, like from medical school, about hyponatremia. I think it's one of those most important features of neuromedicine, and you need to have it straight in your mind. All hypotonicity is associated with hyponatremia, all. But not all hyponatremia is hypotonic. There's three kinds of tonicity. Remember, is functional osmolality. It's the ability of the osms to suck water into the cell or suck water out of the cell. That's tonicity. So there are three kinds of hyponatremia. There's isotonic, hypertonic, and hypotonic. The isotonic form is really not a problem these days because the lab actually fixes this for you. In the old days, when I was training in medicine at Boston City Hospital, you had to do this yourself. You'd take the tube of blood and you'd look at the plasma. And what you'd see is fat in the plasma from people with very high cholesterols and lipids, taking up space so that the actual measurement is an artifact. And you just ignore it. It's not a disease. It's just something is taking up space in the plasma. Hypertonic means there's external osms. And in medicine, in neurological medicine, that's often mannitol. I mean, actually, that's why we give mannitol, is to produce a state of hypertonicity, to suck water out, to use the tonic forces to fix the cerebral edema. And then there's hypotonic hyponatremia, which is the most common one. And that one we divide into three types based on the volume status. This is old-fashioned medicine. You go to the bedside, you put the person at 30 degrees and you look at their neck veins and you say, are they elevated or not? Remember, tissue rigidity is not a good measure of loss of volume. So because old people get tissue that's loose and they're really normal, there's nothing wrong with their volume status. So basically what you want to look at is their neck veins at 30 degrees of elevation. And as we divide the patients into three types, the hypervolemic type, otherwise known as the edematous type, the hypovolemic type, in which volume is low, and the isovolemic type. If it's hypervolemic, what are the causes of that? Those are the edematous diseases. And somebody asked about that earlier, renal failure, heart failure, liver failure, all are associated with third spacing of water. And they can produce hyponatremia. But none of those exist in this patient. Then there's hypovolemic types. These people neck veins are flat at 30 degrees. And it's very, very often it's the use of diuretics. Diuretics are commonly used in medicine, right, for treatment of blood pressure and benign kinds of edema. Blood loss is an example of this. A salt wasting nephropathy, including the cerebral forms. Those of you who talk about cerebral salt wasting, by the way, there's nothing different about it. It's just cerebrally induced renal salt wasting. All salt wasting is renal. And of course, Addison's disease, in which the potassium would be elevated. The potassium, remember, was not elevated. So this is not Addison's disease. In this era, Addison's disease is either autoimmune multi-endocrine failure or tuberculosis. And he could have had that, but he doesn't have an elevated K. So he doesn't have Addison's disease. So that leaves us with the final form, isovolemic, hypotonic hyponatremia. And this includes the osmotic forms, hyperglycemia, for example. This guy has hyperglycemia. There's an argument about whether you can reset your osmostat just by aging. And there are some people who, as they grow older, lower their sodium a little bit. And you can't find a cause for it. they've reset their hypothalamic osmostat. And so they live at a lower serum sodium. It's not really a disease. Spinal cord injury will disconnect the hypothalamus from the lower organs. Hypothyroidism, massive polydipsia. It's a very, very hard thing to do, by the way. I remember in medical school, we had an experiment where we had to drink a huge amount of fluid ourselves. And we had a choice. We could drink either a weakly salty fluid or a smaller volume of a very salty fluid. Which would you choose? By the way, both bad, make you very nauseated. And so we tested each other by drinking either hyposmolar fluid or an isosmolar fluid, 0.9 isotonic saline, and then just measure our urine output and urine osmolality. And it was basically impossible to drink enough water. A normal young person to drink enough water to make yourself hyponatremic. It requires massive water drinking. Usually associated with psychiatric illness, as I'm sure you know. And it does occur usually in older people who can't compensate as well as younger people, but it's very, very rare and very hard to do. And then there's the syndrome of inappropriate ADH. So the antidiuretic hormone is being secreted at a time it shouldn't be secreted because it's being made by a lung cancer or an inflammatory disease like Guillain-Barré syndrome. Do you ever wonder, why does Guillain-Barré syndrome cause hyponatremia? After all, Guillain-Barré syndrome is mostly a myelin disease, and the autonomic nerves are not myelinated. So why should they get hyponatremia? They do. In fact, if they're not hyponatremic, I often think they don't have Guillain-Barré syndrome. I mean, it's almost 100%. And some of them, life-threatening hyponatremia. So it turns out it's very cool. It is demyelination, but it's demyelination of the afferent nerves that are carrying information from the atria to the brain about volume status. So when those nerves, which run in the glossopharyngeal nerve, going back to the medulla, are demyelinated, the central nervous system thinks, well, thinks is a little strong, that let's say thinks that volume is down because it's not getting information from those nerves. And so it secretes ADH. So it's actually not inappropriate ADH, is it? It's appropriate ADH in the face of inappropriate information coming from the nervous systems. That's how Guillain-Barré does it to you. Something to keep an eye on, because I've had patients who have such severe hyponatremia that start to have seizures from Guillain-Barré. So let me just use one more slide and then we'll open it for discussion again before I give you the denouement on this case. So we treat these different kinds of hyponatremia completely differently. These are completely different diseases. In the first place, the isotonic form is not a disease at all. It's an artifact. You don't treat it. The hypertonic form, you have to remove those external osms if possible. When I say if possible, I'm serious, because what if the external osms are given by you to treat cerebral edema? I mean, you gave the mannitol. So you're caught between Scylla and Charybdis, between a rock and a hard place, right? Because you've given the osms for a reason, and now the osms are causing trouble. And this, of course, happens in the neuro ICU all the time. Now, of the hypotonic type, if it's hypervolemic, the edematous type, we treat those people with sodium restrictions, right? Because we're trying to reduce volume. And we try to treat the underlying disease, provided we can. CHF, we treat the heart failure. Renal failure, we treat the renal failure. Liver failure, we treat the liver failure. Not the case in this patient. Remember, he had normal LFTs and normal RFTs, and he wasn't in heart failure. In the hypovolemic form, we treat them with volume, including sodium. So we will give them normal saline, 0.9, normal saline, or even hypertonic saline. It's the euvolemic kind where the trick comes in. And it all depends on how fast the hyponatremia developed. If it happens in less than 48 hours, and I'll explain to you why this is the case in just a minute, you must give hypertonic saline, 3% saline. Where would that happen? Happens on the marathon route, where a person who's in pretty good shape, but not really world-class shape, decides to run the marathon on a hot day. And as they're running the marathon, they're drinking free water that good Samaritans give them along the way. Those people can become severely hyponatremic rapidly. And what that will do is cause acute cerebral edema, life-threatening. Just a couple of years ago, we had a person who collapsed about halfway through the marathon. She just fell to the ground. And by the time they got her to a local hospital, she was dead with cerebral edema. I mean, the EMTs need to give 3% saline instantly if you think it's developed in less than 48 hours. On the other hand, if it's developed, and this is much more common, of course, very, very slowly over weeks and months, the brain has a trick that it utilizes that no other organ utilizes. And the reason that that evolution developed this trick is that the brain is encased in a rigid container in the skull and the spinal column. It can't afford volume shifts like the kidneys can, or the gut, or the liver. What happens if the liver enlarges a little bit and then shrinks a little bit? Nothing. But if the brain enlarges, you've got big trouble and fast. And in a second, I'm going to tell you what happens when it shrinks rapidly. So what the brain does, it's learned to do over eons of evolution. As the hyponatremia is developing, hypoosmolarity, it extrudes osms, pushes osms out in order to maintain its volume. So the brain doesn't swell like it would in an acute situation. The brain stays exactly the right size. But now it has fewer osms inside itself. So along come the doctors. And the doctors give sodium chloride, which is hyperosmolar to this person, right? Because they've extruded their osms. And so the brain suddenly shrinks. And that causes osmotic myelinolysis. The myelin suffers, and the places where it suffers, of course, is where the tracts are all crossing, and there's no room for any air in volume. The pons is the famous place, of course, because in the pons you've got descending fibers and crossing fibers in the base of the pons, so it's really at risk. But we know that that osmotic myelinolysis, although it occurs primarily in the pons, can be extrapontine, and it's always in a place where it's tight. So if you see somebody who's, no matter how hyponatremic they are, I mean, down to numbers that are staggering, double digits. I had a patient once with a serum sodium of 98 who walked in. The treatment is water restriction, and you certainly do not want to raise the serum sodium by more than about 4 or 5 milliequivalents per liter per hour. No faster than that, because if you do, the brain will suddenly shrink, and you will produce osmotic myelinolysis. You can give loop diuretics, and you can then actually block the vasopressin receptor, and we have drugs that do that now. Conivaptan was the first one, and it saved the life of a Guillain-Barré patient of mine. who got so hyponatremic that nothing worked to bring the sodium up. So we blocked the vasopressin receptor with conivaptan, and it saved her life. She was getting confused and probably would have started to have seizures. So let me just show you what it looks like. This is what was called central pontine myelolysis at first. Remember, this was discovered in alcohol users totally incidentally out in Cleveland by Morris Victor, where they found this lesion that was restricted to the pons initially. But there you see extra pontine myelolysis. You see how it goes up into the internal capsule, producing that spasticity and upgoing toes that we saw in this patient. And even into the insula. That's extra pontine myelolysis. Now I like to call it osmotic myelolysis. Look at that. There's a T1 picture of mid-sagittal picture of somebody with pontine myelolysis. And people can walk away from this. I mean, it was discovered in autopsies, but people can walk away, and they're left with spasticity and weakness in their limbs. People who walked away from attacks of osmotic myelolysis. So let me summarize what I just told you. The treatment for hyponatremia depends entirely on the rate of its development. So you probably were taught that there was an argument between nephrologists and neurologists about whether to give sodium chloride or not. And there was, because they didn't realize they were talking about two sides of the same elephant. And they were both working on the same problem, except one group, the nephrologists, were worried about acute hyponatremia, the treatment for which is sodium chloride and hypertonic sodium chloride. And the neurologists were talking about chronic hyponatremia, which was caused by rapid correction of hyponatremia. So they were not in disagreement with each other. They were talking about two different problems in isotonic hypovolemia. So in acutely developing less than 48 hours, the brain swells, the cells will swell, increase intracranial pressure. In chronically developing, the brain is the only organ that compensates by extruding those osms if upon this compensated substrate a hyperosmolar fluid is administered, even ordinary normal saline. Then the brain cells will shrink and you'll get myelolysis. So what about hypernatremia? This patient, we were talking about the other side of the coin, weren't we? So now turn the coin over and apply the same rules. So in acute hypernatremia, which is a few hours in developing, there's no time for compensation. The brain edema is the problem, and hypertension is required. This is hyponatremia. And I just told you these, I'm not going to read it to you again. But what about the other side of the coin? If hypernatremia develops acutely, there's no time for compensation. The brain shrinks and you get osmotic demyelination. So in other words, not iatrogenic, caused by bad hypernatremia coming on fast. And the reverse is true with chronic. So think of it as the flip side of the story of rapid correction of hyponatremia. So what was it? What were the mysterious osms? And it was this good old Listerine. I don't know whether you knew this, but a lot of people who use alcohol will buy Listerine as a source of alcohol. Look at a close-up here at the various ingredients, but notice the inactive ingredients: sorbitol, alcohol, 21.6% alcohol in this colored version of Listerine. Just to remind you about Listerine, it was invented in 1879. It was a topical antiseptic. The active ingredients are phenolic compounds at about $8 a quart over the counter. I calculated it would actually be cheaper for somebody to buy cheap alcohol in a liquor store than to buy Listerine in a CVS pharmacy. But unfortunately, people don't know this fact. And the classic form that clears Listerine is almost 27% alcohol. So let me summarize what happened to this guy, and then we'll have a few minutes for comments or questions. So what happened to him? Well, he was using Listerine, which supplied both alcohol and osms to him. His osmolality rose gradually over weeks or months. The brain cells compensated by retaining idiogenic osms, not just the opposite of hyponatremia. Then he lost access to his alcohol and osms. He was hospitalized at the outside hospital. And he developed alcohol withdrawal. Rapidly dropping osmolality resulted in cerebral edema. That's why he had invisible venous pulsations and blurred optic discs. And the initial alkalosis was, as a person in the audience very astutely said, was due to salicylates. And where did he get the salicylates? From the Listerine. Listerine contains salicylates, which caused him to hyperventilate. As this wore off, he developed a respiratory acidosis. Then he was given benzos. Do you remember that? That aggravated his respiratory acidosis, almost killed him. He went to a PCO2 of 98 after he was given benzos. Had to be intubated. Fortunately, he didn't develop the permanent deficits. And when he awoke, he told us the truth. He said, I used the Listerine for source of alcohol. So those are my 4 messages to you. Osmotic myelolysis is actually a dynamic process. You can watch it happen right before your eyes, as we did here. Brain can swell, brain can shrink, depending on what side of the coin you're on. Hyperosmolality is nothing but the flip side of hypoosmolality. The speed of development of osmolality disorders determines the safest therapy. And the brain has this unique method of handling these challenges. This is the paper by Bob Lorino at the Washington Hospital Center now, when he was in Cleveland with Morris Victor, discovering that the cause of osmotic demyelination, osmotic myelolysis, was rapid correction of chronically developing hyponatremia. And I wanted to show you a picture of me with Bobby Lorino. That's Bobby right there next to me in the open white shirt. And there I am. You can tell that's me because of the ears. There we are in 1956 or something like that, 1955, in elementary school together. So he's one of my oldest friends in the world, and he's made a spectacular contribution, really an expert in all electrolyte disturbances, but he's famous for this discovery about osmotic myelolysis. By the way, I tried to call it osmotic demyelination, and he corrected me, as he always has ever since we were kids, and said, no, Dr. Adams, Raymond Adams, who published the paper with Victor, particularly and specifically called it myelinolysis, because they didn't want it confused with multiple sclerosis, a demyelinating disease. But this was an osmotic disease, not a demyelinating inflammatory disease. So I've gone back, and Bobby told me to do it, so that's what I'm doing, calling it correctly. So those are the messages from this one very, very interesting case. What do you think, Dr. Milligan?
That was so wonderful. What a great mystery case. It unfolded like the best of mysteries to a satisfying conclusion.
Even Miss Marple would have had a hard time with this case.
That was a good one. That was a good one.
We didn't know until he woke up. We said, what do you drink? You know, it was a good question. Somebody said ethylene glycol. We knew that he had some kind of mysterious osms, didn't know what it was. He told us it was Listerine. I actually didn't appreciate that Listerine had osms and had that much alcohol in it.
Yeah, that's really interesting. You know, having spent some time in a location with a heavy incidence of alcohol use disorder, and the liquor stores being closed on Sundays, this happened more. I think, your point about the price point, but when the liquor stores are closed and the Walgreens is open, or the antifreeze is available, then you see, unfortunate things like this.
Yeah, it's sad, isn't it? It's terrible. But I learned a lot from taking care of this one man.
Well, thank you for presenting that case. That was great. We'd like to get any last questions or comments from the audience before we close our session. We still have a couple of minutes. Somebody had put in a question about how about hyponatremia that's caused by carbamazepine or Tegretol. So that's
Yes,
something.
Yeah, oh, sorry, you go ahead. You're the expert in that.
Well, I would say as an epileptologist, definitely see that from carbamazepine. And there's a much higher risk of that happening when somebody is taking a SSRI. They both can have this effect of increasing the sensitivity to ADH. So there may be some increased release of ADH, but the kidney becomes more sensitive to the ADH that is there. And so we can treat it with water restriction. Were you going to say something differently, Marty?
No, just exactly what you said, that, there's two receptors there in the kidney. Vasopressin has two different effects. One is the effect on water in the kidney, and the other is on the blood vessels, right? Which is why we call it vasopressin. And it's that renal receptor that we're interested in. That's what we can block with the conivaptan if we have to. I mean, we don't use conivaptan unless it's an acute, serious problem with unresponsive hyponatremia.
So somebody had mentioned the analogy of Sherlock Holmes. So we went from Miss Marple to Sherlock Holmes. And we love this. In neurology, we get to do a lot of this detective work in many areas of medicine.
Well, as Holmes said, when they found the body at the bottom of the stairs, it's obvious that she's dead, but the question remains, did she fall or was she pushed? That is a very important Holmesian thing to remember about neurology. What was the cause of the loss of consciousness? And in this one, you can put it all together piece by piece as a single parsimonious answer. It's Occam's razor. Beautiful example of Occam's razor.
Yeah, very nice. There was another comment, one last comment we didn't get to. Urea is an emerging therapy for SAADH, especially when fluid restriction is not an option, with a link there. So thank you for sharing that. The conivaptan is that the most modern way?
It is. There's son of conivaptan and grandson of conivaptan, but they're all V2 receptor vasopressin type 2 renal receptor blockers.
All right. Well, thank you, audience. Thanks for being so interactive too. We really appreciated all those questions and comments and links that you shared with one another. And I recorded this as well, so I'll be able to post that if that's okay with you, Marty.
Of course.
People who weren't able
Sorry,
to.
the dogs are acting up.
Who want to go through the mystery case again and follow along. So thanks so much, Marty.
Okay. Bye-bye.
Bye, everyone.
I just have to figure out how to close this.
Oh, Marty, did you publish this as a case report anywhere?
I don't think it's been published. I presented it at the American Neurological Association once as just an interesting medical neurology case. It's a cool case, isn't it?
It is. It is.
It's a way to learn about it so that you don't forget and get mixed up as to whether you should be giving hypertonic saline or not.
Oh, and so many people fascinated by neurology are fascinated by nephrology and acid base. Are there people who are neurologists who like to do acid base problems for fun?
Yeah, so you're talking to one.
I know.
Acid base problems are fun to do. They are. If that were all there was to nephrology, I might have been a nephrologist.
Excellent. Oh, bye, everyone.
Bye-bye.